everybody. My name is Emily Young. If we haven't met, I am one of the DSA reps for this year for the department, and we are excited to have another opportunity to invite a guest for one of our Wednesday seminars. And we're very fortunate today to have with us Pari Chowdhary, who is a technical advisor for sexual and reproductive health at CARE. And I believe Pari is leaving for Colombia in like 2 days. So we're very lucky that she had time to join us today to share about one of the projects she works on related to supporting adolescent sexual and reproductive health in crisis settings. Prior to working at CARE, Pari lived in several different countries doing public health work along the same lines in Thailand, India, Tanzania, I believe, and then moved to the United States to pursue an MPH at the School of Public Health at Emory. And ever since, she's been at CARE. So I will turn things over to Pari again. Thank you for joining us today. She'll present for a bit, and then we'll have questions at the end.
Thanks, Emily. Hi, everyone. I am actually a senior technical advisor, so that's fun. Okay, so folks, today I am going to be talking about a specific program called the AMAL Initiative, which stands for Adolescent Mothers Against All Odds. And I picked this program specifically because, I thought it would be a good opportunity for all the diverse perspectives in this room to sort of come together and discuss the actual application of academic research around the needs of adolescents and sexual and reproductive health programming in different settings, and also perhaps to discuss some of the practical challenges that take place in the field as opposed to when we do research about things. So I'm going to walk us through this program, and then I do have a few opportunities for us to do a little bit more interactive work. And given the hybrid design of this session, I think what I'll do is, instead of splitting folks into groups, I'll just have everyone brainstorm by themselves. But I am happy to take questions as they come. I just can't see the chat box. So what I'll do is I'll pause along the way and have opportunities for questions. So the AMAL Initiative, which stands for Hope in Arabic, is essentially an approach that was developed by CARE and UNFPA several years ago to encourage participation of pregnant adolescents and first-time mothers in crisis settings in playing a more active role in advocating for their own sexual and reproductive health. And we started the program in Syria. It has now expanded into Nigeria, Lebanon, and Iran. Obviously, the program in Iran has since changed. The program in Syria has also since changed. But that's part of what I'd like to discuss today in terms of the ever-changing nature of our work. So just to walk us through what we're going to be doing today, I thought I'd start with providing some context around the AMAL Initiative, talking through some impacts that we've measured across the program, and then focusing in on lessons, and then working on a more interactive activity together as a group, which was actually a real-life scenario that we experienced in the field. So to get us started, the AMAL Initiative essentially came about as a result of some concerted work across a consortium of organizations in the Middle Eastern and North Africa region to realize that, adolescents have specific vulnerabilities within crisis settings, and within adolescence, there are special subgroups that experience an increased risk of those same vulnerabilities. And now we know that from the research and the literature, but what we realized is that we were seeing, as a result of a long-term protracted crisis in places like Syria and Nigeria, that the vulnerabilities that adolescent girls especially were experiencing were changing over time, but staying at the same level of risk. And so what we were started to think about was that, in humanitarian emergencies, of course, every person within a population is disproportionately affected in some way or the other, but adolescent girls especially are at increased risk of particular things. And I've outlined here those on the slide here, but essentially, a loss of the structures and the infrastructure that they're used to, they experience a higher risk of child marriage and forced marriage in those scenarios. a high risk of sexual violence, high risk of coerced sexual activity, and forced recruitment into armed groups. And of course, all of this is happening while they have limited access to health services that they used to previously be able to access, which is especially challenging because it's a time at which they arguably need those services more than before. And so we were realizing through our programming and research that was coming out at the time that girls are obviously facing all of these things in humanitarian emergencies, but they continue to face these crises and more when a humanitarian emergency becomes a long-term protracted crisis, like it did in Syria. And we also realized, as I mentioned earlier, that not only do adolescent girls experience this level of risk, but there are particular groups of adolescent girls that are subgroups that are even more vulnerable than the larger group as a whole. And so we started to explore that together, along with a consortium of organizations that was working in the MENA region. MENA is Middle Eastern and North Africa. And that is essentially what led to the development of a strategy that is shown here on the right side of the slide, which is the whole of Syria strategy. So essentially in 2018, multiple organizations across the MENA region came together and put together this strategy specifically addressing the needs of adolescent girls in Syria. And the focus was on Syria because of the fact that Syria was presenting a unique situation where a short-term acute crisis had turned into a long-term protracted crisis and would continue to regress into acute situations based on resource limitations or things like that. And so Amal came to be because UNFPA, CARE, a whole cluster of organizations realized that there was a necessity for programming specifically for first-time mothers and pregnant girls. So between the ages of 10 to 19. And that was when the Amal initiative was developed. The Amal initiative, like I said, it was piloted and initiated in Syria, and it then grew into Nigeria, Lebanon, Jordan, and Iran. But the largest implementation of the Amal initiative continues in Syria. So the Amal initiative itself is essentially a curriculum. It is made up of 3 primary components and 2 additional components. The curriculum addresses 3 target populations. So we all know that you cannot make change for the lives of a vulnerable population without also somehow impacting the norms or views or behaviors of their societal and familial networks. And so when Amal set out to say we need to improve the reproductive health and lives and well-being of young girls, we realized that we also needed to engage their mothers-in-law, their husbands, their community members, and health providers in programming. So the Amal Initiative's primary target population is, as I mentioned, pregnant girls and first-time mothers between the ages of 10 to 19 years. And so the first component is directed at them. The component is essentially an 8-week curriculum designed to improve not only their sexual and reproductive health knowledge, but also their communication and negotiation skills, their awareness around pregnancy risk, how to better take care of themselves while pregnant and during postpartum periods, and also helps them negotiate their own familiar relationships. So there's a particular session within the 8 weeks that is focused on talking to your husband or being able to advocate for yourself in terms of timing of sex and timing of pregnancy. The second component addresses the views and behaviors of community members that are within the girls' social and familial circles. So essentially we get influential community members like religious leaders, other gatekeepers, teachers in the community, and of course the mothers-in-law and husbands of the girls. And we engage them in a 7-week-long curriculum where they are essentially going through a very intense reflective dialogue and values clarification process around things like gender, power, and social norms, with the idea that by the end of that curriculum or that 7-week period together, they have a slightly more nuanced and finer sense of what is an inequitable norm and how they can potentially target it. for remedying it, for improving the lives of the girls. And finally, we realized that ultimately Amal is, while it is working on gender and power norms, like I just described, it is ultimately directed at improving the sexual and reproductive health of the girls. And we can't do that unless we have the very last step figured out, which is where health providers in the clinics within catchment areas are actually equipped to provide adolescent-specific care, are reducing their biases around providing care to adolescents, and of course have the knowledge, awareness, and supplies to be able to provide family planning and contraception and sexual and reproductive health to girls. So health providers make up the last component of the program. They are engaged in a 4-week-long curriculum where they are also going through values clarification, but then receiving training and education on how to provide adolescent-friendly services, how to reduce your own personal biases around provision of family planning and contraception to adolescent girls. So those are the 3 main components. And then we have an overarching piece called the Community Advisory Group, which is essentially our way of doing continuous quality improvement of this program. So one of the goals when we were designing the Amal initiative was to not just create a program that addressed the vulnerabilities of this subgroup, but also create a platform for meaningful participation and engagement of adolescents. If you are familiar with this body of research, most of the time when we have adolescent focused programs, they are designed for adolescents rather than with adolescents. And one of our intentions of this program was to kind of pilot and test opportunities for meaningful participation of adolescent girls in design, implementation, and evaluation, which has not previously been done in a humanitarian setting. Because most of the time in humanitarian settings, when you think about the needs that a program is trying to address, they are what's considered more immediate, where it's like, shelter, safety from violence, supply chain, commodities, and bridging service gaps. So in this case, because it was a long-term protracted crisis, we were like, well, maybe there's an opportunity for us to also actively engage the girls in the design of this programming, which is where the Community Advisory Group comes in. The Community Advisory Group essentially takes players from all 3 components. So it takes girls, community members, health providers, and essentially creates this monthly platform where girls are not only encouraged to, but the Community Advisory Group is designed in such a way that girls have a platform to voice the challenges that they've been experiencing with the people in their communities. And then the community members and health providers, together with the girls, develop an action plan that the community then works on and then provides an update within the next meeting. And of course, in order to prepare the girls for this, you can't just put them in a scenario where they're all of a sudden talking to people who are older than them, much more powerful than them, have historically and previously held a different role than the girls have. So the girls who graduated, they like to call themselves that, graduated from the Young Mothers Club and were interested in participating in a more leadership capacity, went through 3 additional leadership sessions where it was a full leadership curriculum for them, essentially to help them work on their advocacy, their ability to stand up for themselves and communicate and feel comfortable talking to a group of adults. So in those sessions, they essentially went through these practice rounds. We helped provide them with skills about how to distill information, how to present their case, and so on. And unexpectedly, a lot of the girls who went through those leadership sessions even went on to do other things within their communities after Amal. They recruited girls from other villages and spaces into the program. They started to work with health providers at clinics to just provide providers with ongoing sort of education around how to talk to and deal with adolescent clients. So that was an unintended consequence, but a lovely one. So I'll just briefly discuss the impacts of the program, just to say that, we did have a full scale evaluation that was done across all the countries. The Amal toolkit, which is made up of the curriculum, also includes standardized monitoring and evaluation tools. And so because of that, we were able to collect data across the same set of indicators from every implementation, as long as they maintained fidelity with the core components of the program. So just to share that in Syria, the program was implemented it's been implemented since 2018, but the results that I'm about to share today are from a 2-year evaluation that we did most recently. And it is being implemented in Northwest Syria, which, if you are familiar with the context, has been under heavy conflict for about the last 12 years. And so we had 811 girls participate in the program, 732 community members, and 142 healthcare providers over those 2 years. And we had a bunch of different implementers implementing the program because in Syria, you cannot have a foreign NGO like CARE go in and provide programming. So we partnered with organizations on the ground to do that. In Nigeria, CARE itself was the implementer, and we implemented in Borno State, which, if you're familiar with that context, is where Boko Haram operates. And we had 288 young girls, 240 community members, and 60 healthcare providers participate in the program. And I'm flying through this a little bit because this was just to give you a sense of who was participating in this program and where. But essentially on this next slide, I just want to show that we collected across all of our contexts, we collected a standardized set of information against a standardized set of indicators. So for all participants, we explored their support for girls' use of family planning and their support for girls exercising their reproductive rights before and after implementation of the program. And then specifically for the girls, we measured their self-esteem, their ability to communicate, and their confidence seeking healthcare. For community members, we explored their ability to recognize unequal gender and power norms, their interest in changing those norms, and their ability to support girls' equal access to services. The funny thing about this one was that their interest in changing the norms was always way higher than their ability to recognize the norms. So that was something for us to think about in the future, is like, why is that happening? And then we looked, of course, at health providers, since they are the final component. And for health providers, we looked specifically at what level of comfort they had providing family planning to adolescent clients, and then their support for girls' choice to use family planning, and the recognition that they have of their own personal influence in a girl's ability to exercise reproductive rights. And you'll see that we had positive outcomes across all indicators. Of course, there's nuances to each of these. Like, for example, under health providers, you'll see that their support for girls' choice to use family planning we saw a 19% increase between baseline and end line. And that's a lower change than the rest because their health provider support for girls' choice of family planning was always overwhelmingly positive until you brought in certain qualifiers. Like if you said, would you still support a girl's choice to use family planning if her husband was against it? Then the numbers would decrease significantly. Or if you said, if she was in her first year of marriage, the numbers would change. If she was unmarried, the numbers would change. So these kinds of things were helpful for us to understand, like what are the biases and norms that we need to spend more time tackling. And it's been helpful for us to understand through this data how we could potentially expand the program in the future. But in general, we saw an overall positive increase across the program. But we recognize that, ultimately evaluation tools that are developed and administered by the same organizations that are implementing a program can be considered subjective. So we also went ahead and looked at health facility data. So we explored facility data from facilities that were within the catchment areas where AMAL was being implemented in both Syria and Nigeria. And we explored their proportion of adolescent clients for particular health services. And there's a tremendous amount of data around that. I just pulled a few that are relevant to our conversation today. In general, we saw the adolescents' use of family planning services double across implementation areas over the 2-year period that AMAL was being implemented. We saw increases in the use of antenatal care, skilled birth attendance, and postnatal care. And of course, we can't say with certainty that AMAL is responsible for these changes, but because of the closeness with which we were working with the health facilities and the health providers at those facilities, we can say that Amal in some way contributed to this. Family planning, antenatal care, skilled birth attendance, and postnatal care were all direct topics that the Amal curriculum covered. I'll pause there and ask if there are questions. The next section goes into a larger global evaluation that we had, but any questions about either impacts or implementation areas? Yeah, I see one.
Hey, thanks so much for this talk so far. I was just at the IRC and we had a lot of really intensive discussions around things like power dynamics with CAGs, and I was wondering it'd be great to hear from your perspective, especially since you're talking about like an age and gender power dynamic, right? With adolescent girls, is how you balance those power dynamics, and if there were any accountability commitments, for example, that community members needed to make. And then the second question is actually around norms and family planning and just really taboos around sexuality, right? In adolescent girls, especially with premarital sex. And so it'd be great to hear how curriculum-wise you tackled that topic of like sexual purity, and just given how ingrained it is, especially in the MENA region. And and if there were any sort of restrictions when it came to being able to do programming with married or unmarried girls based on those kinds of norms.
Yeah, absolutely. I'm just writing this down so I make sure I hit both of those. Okay, so your first question was about accountability measures. So one of the very interesting things that I don't think we necessarily went into the program knowing, but walked out of it realizing, was that part of the success of the ML initiative was simply because we had designed the community component, which is component 2, with this idea of collective responsibility. So the intention was that the first few sessions with community members focused heavily on reflective dialogues around values clarification, about how they explored the differential norms between boys and girls. What were their views on family planning use? What were their views on the need to have children soon after marriage, and so on. But the curriculum built in this concept of collective responsibility in that it essentially helped assign the members of the community component this essentially this power that they were now responsible for the lives and well-being of adolescent girls within their spaces. And we didn't know how well it would work, but when we did our qualitative research following the end of the program, most community members said that that was a large part of what made them feel like they needed to play a role beyond just the sessions of the program. So I wouldn't call it a traditional accountability measure, but that was one of the ways in which we had built in accountability into the program. The second was that for the CAG, since you mentioned that, each time that there was a CAG, there was a set of action items that were developed that needed to be worked on. And so there was an action plan that was developed along with assigned responsible persons that were then responsible not just for carrying on the task, but following up on it and reporting back on it to the full group. So there was sort of a natural form of accountability built in as well. CARE also has this very well-established social accountability tool called the Community Scorecard, which was not used in full for Amal, but some of the action plans that the communities developed automatically sort of built in this idea of like grading themselves on how they're doing related to certain things. So like, for example, one of the very concrete items that was brought up during a community advisory group was that the girls felt like they could not go to family planning clinics because the people at the clinics knew them. And they weren't sure if the providers would maintain confidentiality about the services that they were getting. So they felt uncomfortable and nervous doing that. And the action that came out of that was that 2 of the health facilities in that area developed adolescent-only hours. And so there were particular hours of the day where no other clients could come in. Another facility created a different entrance for adolescent clients. And then, of course, it did confidentiality training with health providers. But yeah, so those were the accountability mechanisms that were built in. Second were power dynamics. And the truth is that despite the positive changes that we saw I don't think that CARE or any organization can ever claim to really shift gender and social and power norms within, a 2-month implementation, maybe not even within a 5-year implementation. So what we were seeing was more so that the girls themselves were just reporting on their self-esteem and their confidence ability in terms of talking to their family members and their community members about their issues. And one of the ways, this was not a smooth process by any means. We had an easier time of it in Nigeria than we did in Syria. In Syria, the girls, even after the leadership sessions and after knowing that the community had undergone their own sessions, we're still not so sure about the receptiveness of the community towards hearing them talk, since they'd never done that before. So they actually have their own idea where they asked us to convene all of their grandfathers, not their fathers, but they asked us to convene their grandfathers, and they practiced by talking to their grandfathers because they felt like that was a safer space for them to do that. And they were able to sort of they were more comfortable challenging the power dynamics between their own family and people they knew than strangers. And so that's how they leveled up to eventually talking to the community, but they started with people they knew. And in terms of unmarried versus married, this is a question that I think occurs every time CARE has an adolescent reproductive health program, not just for AMAL. For AMAL, we specifically honed in on married adolescents. And the reason for that was just because we realized that they were a particularly vulnerable group to intimate partner violence, gender-based violence, and maternal mortality from early childbearing. And so we had identified married girls only as our target population. And so that was a little bit, we were a little bit insulated from those issues because we weren't we weren't targeting unmarried girls. Having said that, we did look at norms for providers amongst unmarried girls just because we wanted to know for future work, which is why I brought up the fact that they had issues with unmarried girls going through family planning, which makes sense because the program curriculum did not in any way address whether people did not address that providers should shift their attitude specifically on unmarried girls, because we had only 4 weeks of curriculum with them. So we focused on reducing their biases around providing care to married adolescents. That was a very long response, but I hope it helped. Okay, well, I don't see any other questions, so I will carry on, but happy to take them as they come. So for this part, I'll just share that CARE UNFPA embarked on a very, very large scale global evaluation that was not as focused on impact and outcome measurement, but more so understanding the program elements and process elements of implementation. So we looked at 3 overall themes. We looked at localization of programming. So CARE developed this program in 2018. This program has since been carried on and implemented by multiple other organizations that are not CARE. And so there's been a lot of lessons about how to generate and create feelings of local ownership and to sort of shift the power dynamic from, an American-based NGO to allow organizations to create their own adaptations to the program and so on. So that was one of the themes we explored. The second theme was very much in line with that. We explored how you could adapt the program while also maintaining the core components so that you have fidelity. And so that involved a lot of exploration of looking at how the program had been rolled out in the multiple contexts where it had been. One of the unique things about AMAL is that it is currently being implemented both in acute emergency settings, long-term emergency settings, full-blown communities, and also refugee camps. And so I think in each case, there were certain adaptations that were made, and we were trying to identify what it is that can be teased out that makes up the core program so that you can still call it AMAL and evaluate it the way that it's intended to be evaluated. And the final theme, which is what I'll focus on today, that we looked at was meaningful participation of adolescents. So we were really keen to understand what a program needs to really do in order to be good or effective at really elevating the voices of adolescents even in crisis settings. And essentially, we found that it boiled down to 3 pieces. The first is leadership building, which is essentially, skills building and training to allow girls to have not just the capacity to do it in terms of like instruction, but also their own, to have a sense of self that allows them to feel like they are capable of doing it in the first place. And now I will say, like, leadership building to me, again, is not a revolutionary thing. Like, CARE is not at all the first organization to do this. Leadership building is just something that makes sense in if you are trying to empower a group of individuals who previously have not perhaps had space, opportunity, the voice to be able to do these kinds of things. I think the parts that Amal did that were perhaps newer to the space, or at least in combination with everything else it did, were more effective, were the next 2. So the Amal initiative, through the CAG and through the leadership sessions, created very intentional platforms for sharing between adolescent girls and their community members. It also created spaces for dynamic shifting between mothers-in-law and the girls that had previously not necessarily existed. And so the girls not only have these chances to be able to present to their communities, but the community had committed in a very concrete way to sort of doing something about the feedback that they were receiving through that action planning process. And that leads us to the next piece, which of course is linked, but this idea of collective responsibility, where you are creating accountability mechanisms through, through these sessions that you're having with community members, so that you're engaging social and familial networks in the programming in a very conscious way. And the idea of collective responsibility is sort of what allowed us to come up with these key takeaways that we had for adolescent programming, which is that, most of the time when we work in humanitarian settings, I alluded to this earlier, but there are a lot more, even from a donor's perspective, typically there's a lot more immediate needs that people think of than, let's say, empowerment of girls for their reproductive health. They'll think of like actual gender-based violence prevention or safety provisions, protection mechanisms. But what we were trying to put forward with this program was that, adolescent responsive programming is not just needed, but it's also feasible in crisis settings, as demonstrated by Amal being implemented in a few different places. And that if you are able to start to address gender or power norms around the differences between what girls are experiencing, then you could potentially also create an enabling environment that allows an uptake of reproductive health services. Of course, you need a few different things to be in place for that to happen, but because the way the program was designed, it allowed us to facilitate that uptake. And we know that to be true because we have the health facility data to validate that. And finally, I said at the beginning of this conversation that a lot of our programs in the public health, and especially sexual and reproductive health in emergency space, is very much for populations rather than with. And so one of the key pieces that the Amal program is attempting to put forward is that, we should be working with and for adolescents, and that will effectively help us make our programming more effective and equitable, and eventually take international development to a place where perhaps you don't need organizations like CARE to come into these spaces and say, here's what we suggest, because you have all of the local expertise already, and they have the capacity to then put it together because they've seen previous examples of situations where adolescents are actively involved in programming. I do have a little activity for us, but before that, I'll just offer up that for our next steps for the Amal initiative from CARE's perspective, Amal is currently wrapping up in Syria. It is continuing to roll out, currently wrapping up in Nigeria. It is continuing to roll out in Syria, Jordan, Lebanon, and is next year, in 6 months, going to be starting in Somalia as well. And in Somalia, it is going to be a partial nutrition program. So the idea is that it is being adapted through the global evaluation results to also include treatment for severe and acute malnutrition, since most of the places that are experiencing humanitarian crises are also going through food crises. And so it is being implemented to go beyond just sexual and reproductive health. If you do have any questions about the program at any point past today, you're welcome to either get in touch with me via the email that's listed there, or there is a webpage on the CARE website that is dedicated to this program. We also have 2 open access manuscripts that are out in the world that you're welcome to look at. I'll pause again here for questions before I take us into this activity that I'd like us to work through. Anyone?
I have a couple questions. Can you hear me?
Yeah, hi.
Hi. The first question is going back to the curricula and discussions for community members and health providers. And you mentioned this component about values and sort of values alignment, which seems huge and potentially hairy. And so I'm curious about like who was facilitating those conversations and sort of their training and the approach taken to have those big discussions given the short time frame for implementation.
Yeah. Thank you. I should have actually mentioned this earlier. So one of the benefits that CARE has is that CARE is a 80-year-old organization. And so in neither Nigeria nor Syria was Amal the first thing that CARE ever did. And so CARE had a long-standing relationship with these communities where not only have they been providing health programming for a very long time, but they had also established physical spaces that would be akin to community centers in our neighborhoods, but essentially they were designated women and girls safe spaces where CARE had been working on multiple sorts of things like sexual violence counseling and healthcare provision and family planning awareness and education for different programs. And so I recognize that, it's not easy to come into especially like Islamic contexts and talk about things like sex. But one of I think the major success factors in both cases was that the community knew CARE and they had very long-standing trusted relationships with CARE. So that's part of the puzzle. The next thing is that the people who were implementing the program as facilitators were people within the community who had undergone like a 2-month training process with CARE, and they had previously worked as facilitators for CARE in other respects, and so had received, training on multitude of different programs in the past, and then were then equipped to also be implementing the Amal program. For the community sessions in particular, we always also, in addition to the facilitator of the sessions, we also had a health provider present. The health provider was a co-facilitator, and the idea was for, the provision of accurate health information to be available to the community should they have questions about it. For the health providers, the facilitators were CARE staff. And the reason for that was actually similar in that we wanted to make sure that we were able to target accurate education and information. And we knew that we needed to do that because we did a needs assessment before we started, and we realized that a lot of the providers actually had very flawed views on the value of contraceptives or just like the efficacy of contraceptives, and there was a lot of myths and misconceptions in the space about that. And so we actually had to do a lot of training just to get our facilitators and staff ready to handle those kinds of issues. And one of our lessons, especially for providers, was that the curriculum should probably be longer than just 4 weeks. And I say that because I mentioned this earlier, but there were a lot of qualifiers on some of the changing attitudes with providers. Like they were okay with girls having autonomy, girls having choice only up until a certain extent. They were okay with long-acting reversible contraceptives only up until a certain extent. And I think part of that is very much like you can't shift these values and views within 4 weeks. And it's a good lesson to know, okay, this is something that you need to invest in round 2 or phase 2. Yeah.
Can I ask?
Yeah.
You had a broad range of ages from 10 to 19 and multiple factors that lead to trauma, misunderstanding in terms of violence or early marriage and so on. Do you bracket some of your messages age specific, because 11 or 12-year-old versus 18 have very different experiences and trauma and whatever other issues they've experienced? So how do you handle and partition the information in a way that is specific to the age categories?
Yeah, absolutely. And I'm glad you brought this up, because it actually feeds very well into the activity that I have for us. But essentially, the curriculum, while designed for 10 to 19-year-olds, since that is the official definition of adolescence, is split into 10 to 14 and 15 to 19. And when I say split, I mean that facilitators would lead those individuals through a different set of content. Having said that, we surprisingly have not had a single participant under the age of 14 in the program in any of the countries that we have implemented. And we have been trying to interrogate whether that is because we have an issue with our recruitment, or it is truly that there are no married girls under the age of 14 in those communities. Because that's what we are told when we ask implementers why we haven't seen younger girls participate, is that they're saying that while they are definitely experiencing some of the challenges that we would expect the girls to, that they don't qualify because of the marriage requirement. And if that is in fact true, which I'm hesitant about, it's good news for, the fact that we are potentially seeing reductions in child early forced marriage. But I'm more inclined to think that perhaps that people are less hesitant to let those girls participate. So that's something we need to continue to get better at. But yes, the curriculum is delineated so that it's slightly different. Like a specific example of that is that the session where you are taught potentially how to have a conversation with your husband, negotiating the timing of sex, is very different for the older girls versus the younger girls. With the younger girls, it's the content is a lot more about safety and focusing also on the views of their husbands, as opposed to the older girls where we just walk them through exercises where they're essentially taught advocacy skills. So as I'm sure that several people in this room can attest to, you have to walk a very thin line when you are working on norms that are super ingrained in communities. Like, for example, one of the other programs I work on is in Ethiopia, and it is a family planning program, but it also discusses child and early forced marriage quite a bit. But in Ethiopia, there is a law that says that, you cannot get married until the age of 18. But despite the law and despite implementation of the law in cities, in rural communities, child marriage is still widely practiced. And so you have to essentially find ways to discuss social issues without saying that you are coming in as someone who's a foreigner and that you know better than communities. So I'm not saying that us or any organization has really figured out the best way to do that. I think what we're doing is getting a little bit more creative at addressing issues that perhaps we didn't necessarily know how to before.
Thank you for a great lecture, a very thoughtful answer, and you're brave to be working in the war zone.
Yes, Emily will attest to this, but there are some days where I'm happier than others, and other days you just need to do nothing after work. But if there aren't any more questions right now, I would just like us to.
We have one more question in the room.
Yeah.
Hi, so great presentation, very thought-provoking. You may have commented on this and I missed it, but on an earlier slide when you described the setup for Amal, you mentioned sort of a community advisory group. And I was wondering if you think about you've had remarkable changes in a very short period of time. And as you think about sustainability, can you talk about how you selected those community advisors and whether or not you have a sense of they sort of publicly declared their role on this project, if they were more sort of supported behind the scenes?
Yeah, that is, I really like that question because I think it speaks to the fact that, like, to be honest, we didn't know how this would go when we started it. I mean, of course, it's a heavily evidence-based program, but when I say we didn't know how it would go, what I mean by that is you can't always tell how a community is going to respond to their role in the program. And so the ways in which we selected the community members were right off the bat, the mothers-in-law of the girls who were enrolled in the Young Mothers Club were considered included as participants if they wanted to join, as were their husbands. So those were two groups that were givens. And then other than that, it was actually a different per community basis. So for example, in particular places in northern Syria and along the border of Turkey, Amal is being implemented in refugee camps. And so the community member groups were also made up of camp managers and oversight folks, because those are the people who are just the gatekeepers in those spaces. But in communities, it included folks like Maulanas, which are Muslim religious leaders, and it included the teachers that were at the schools and things like that. In Nigeria, we had a slightly different makeup of community members because the health providers wanted to play a role not just on their own groups, but they also wanted to sit in on the community groups. So in Nigeria, even though their program was newer than Syria, we actually saw more positive outcomes within health providers. And I think that that is at least in part attributable to the fact that the health providers wanted to sit in on all 7 weeks of the community sessions as well. So instead of receiving 4 weeks, they actually received 11 in total. And in Nigeria, another group of individuals that we had participate were just older men in the community who didn't necessarily have a relationship with the girls, but because they just were people who used to sort of sit together in the town square at night, they were the folks who were included in these programs. So in different communities, and then for the second part of your question, in different communities, people had different levels of, I guess, public activeness. In Syria, it was quieter, I would say, simply because of the cultural norms that exist in those spaces. But having said that, the religious leaders and the mothers-in-law and the husbands were still actively action planning, and even reaching the point where they started to ask for meetings with district health officials and things like that. And Syria was the place where they implemented the facility changes that I had said, where they had specific hours just for adolescents and a different entrance. And so that was actually not because of CARE or because of the girls, it was because the community group worked with the health providers to make that happen. In Nigeria, it was, honestly, to me, it was a little bit shocking how on board the community was within like week 1. And I think that part of the reason was because CARE had just wrapped up another 5-year-long program in that community. And so everybody knew what CARE was about. And in Nigeria, the willingness to talk about sexual issues was a lot, like the comfort level was just way higher. And so because of that, the community members were a lot more loud and I guess active about their role amongst even community members that weren't involved at Amal. So people were going door to door. They were creating like their own, they would have their own like these little meetups where they would just sort of all chat about what they had learned. There was a lot of what we call organized diffusion that was happening organically in Nigeria of the program lessons, where it was really only like a few communities that were receiving the official implementation of Amal, but there were a lot of communities outside of that who were starting to talk about Amal and Amal's messages without actually having ever participated in the program, which tells us that there was definitely more participation from that CAG.
Thanks so much.
Of course. So for this next scenario, and this isn't necessarily something we have to do, but I just wanted to share, sometimes when we are sitting, let's say, in our living rooms or in our offices or in our research labs, it's easy for us to say, okay, here's what we need to do. Like, we know that adolescents have specific vulnerabilities, that there are subgroups within adolescence. We know that the WHO defines adolescents as people between the ages of 10 to 19. And we know that Syria has been experiencing a crisis for over 10 years. So we need to develop a program that specifically targets those individuals. What actually happened in practice was that after the first year of Amal in Syria and in Nigeria, there started to be a severe demand from the community for inclusion of older girls or women, basically above the age of 19. And in Syria and Nigeria, this is especially, I guess, expected because the girls who are now, let's say, 21, have actually been going through the crisis since they were 11. And so despite the fact that they no longer qualify as adolescent girls, they have not, unfortunately, received any of the information or education about sexual and reproductive health that girls in the Amal program were receiving. And so CARE had to make some tough decisions to say, we know that we have several considerations, like, for example, our funding is limited. We know that the program design was based on these other evidence-based interventions that only targeted adolescents. That's why we have confidence that it'll work with these groups. If we extend past that, we're not sure about how it will go. But we, at the same time, need to make sure that we maintain buy-in from communities and that idea of collective responsibility. And if you're going against something that the community directly wants or is asking for, how do you maintain that balance or continue to play that game? And so I don't think we should do it because we don't have enough time. But what I would encourage you to think about, perhaps just in your day moving forward, is what we did is we looked at the boxes on the right side of the slide, and we tried to, from the perspective of each of those people, adolescent girls, community members, CARE, UNFPA, and WHO, articulate reasons for and against this concept of extending the program beyond just girls at the age of 19. And the truth is that there's no right answer. In both cases, you're dealing with, there's some pros and there's some cons of that. But I just wanted to share that, you can do all of the work possible under the sun, collaborate with multiple expert organizations and expert individuals in the field to create a program that you think is exactly what would be effective in a particular context. And then the community can come in and tell you that they actually want something else. And I think that that's a valuable lesson for all of us to continue to maintain, is that, the power dynamics that exist even within program implementers and donors and NGOs is very real. And we need to find ways to continue to sort of break down those walls and facilitate situations where money is going to the right places, where it needs to go, and also where the community believes it should go. So I'll just pause there and just say thank you, everybody. And of course, if there are any questions at any point, I'm happy to take them even moving forward.
Thanks so much, Pari. Did you say what the decision was in that scenario? Or is it a mystery?
No, there wasn't a concrete decision. So in Syria, 2 of our partners decided to extend, the other 4 decided not to. In Nigeria, they didn't extend. So it really, it's all over the place. And we're still seeing effectiveness of the programs in both cases. So basically, I'm trying to say that there are sometimes scenarios where there isn't necessarily a right or wrong answer. And you just sort of have to make a tough decision given what you know about the evidence.
Well, thank you so much for joining us today.